you ask yourself, did the investigator assign exposure? Exposure. The answer is, if the answer is yes or no, if it is no, it means it is observational study. There was no exposure of assignment. That is all what we say, intervention, assignment. So under observational study, let's take the right first. We now ask, in the observational study we are going to do, is it have comparison or no comparison group? Some call it control group, but sometimes it's confusing if you use the word control. Because if you use the word control, people will always think you're talking about case control, but you can use the word comparison. If there is comparison, if the answer is yes, then it means it is analytical observational study, analytical. If there is no comparison, then it means it is descriptive study. So under observational study, we have two types, analytical and descriptive. Another name for analytical is comparative, though some people don't agree with it, but you can depend on your lecturers and the school of thought. The genuine name is analytical study, but some people misunderstand this analytical. So, some of us thinking that analytical is something you must do in the, you know what we do in secondary school, analytical chemistry. You must do it in the laboratory where you'll be analyzing a sample. No, it mustn't be chemicals for you to have analytical study. So please let us learn this today, and also help explain to those who have the confusion. So we have two types of observational study, analytical and descriptive. And for you to be analytical, that's comparison. Most of you, I would like you to do only, I know most people in ONG, pediatrics, and those in clinical, basic clinical surgery, what is acceptable is analytical minimum. The situ studies are not usually acceptable for part 1 or part 2, I mean. Unless those, I have seen some people in histopathology doing the situ study. Well, I wonder, but the minimum for part 2 should be analytical study under observational, where you have a comparison group, where you now have a hypothesis, where you now have inferential statistics, because if you are only doing the situ study, there will be no inferential statistics. Now, under analytical now, you ask yourself, what's direction? Because under analytical, we have like 3 types of analytical. We have analytical cohort, analytical case control, and analytical cross-sectional study. Although there's no question about analytical for cohort and case control, because usually they have comparison. What we may have challenges in cross-sectional. In cross-sectional, it can also be descriptive cross-sectional, but here we're talking about analytical cross-sectional, which is also acceptable by the college, some of those in ONG and other college in surgery. So here, in cross-sectional study, so what we'll be asking ourselves is, what's the difference between cross-sectional study, case control, and cohort study? This chart also explained it very clear. So in cross-sectional, the exposure and the outcome are assessed at the same time, simultaneously. So any work you are doing, any study you are doing, that you are collecting data, you're meeting the participants or patients or participants or subjects, and while at the same time getting your sample, that is getting your data at the same time, the same day you met them, it's a cross-sectional study. Some of you make mistake on this. So once you're getting the data on the same day, the same time, you are seeing them. But sometimes you may see the patient, maybe pregnant women at 20 weeks, and you want to check their mode of delivery. You have to follow them up until they deliver. That means you're not going to meet the patient or participant once. You're going to meet them at least 2 times or more times. It suggests longitudinal, so it now becomes cohort. But it also depends. You have exposure to outcome. Why in case control, you have the outcome to exposure. It's a backward design. You understand? So for case control now, let's say you have a case of, you want to study about ovarian cancer. Ovarian cancer. But you want to know whether what factor in them made them to have ovarian cancer. Maybe you want to check whether those who receive oral contraceptives had more of ovarian cancer. You understand? So the starting point is the outcome, ovarian cancer. So you're going back to ask them to whether they had ever, maybe in the last 10 years, they received oral contraceptives, OCP. And for how long? Maybe for 6 months or so, or 10 years, I don't know. So that becomes, so you have those who have ovarian cancer and the other group who did not have ovarian cancer. From the outcome now, you go back to know whether, for among those who have ovarian cancer, how many of them had OCP within the last 10 years? Those who did not have ovarian cancer, how many of them received OCP in the last 10 years and they didn't have ovarian cancer? That is case control study. But in cohort study, here you start from exposure to outcome. You understand? You have to, from exposure to outcome, you want to determine how many of them, for instance, those that have, you want to check the effect of cervical length on preterm delivery. Or you want to check the effect of Prima-Quick in predicting women that will have preterm labor. So you tested them maybe at 20 weeks with Prima-Quick. One group who tested they're all pregnant exposure, or they have maybe who had sacrilege as an exposure of it, or who had a previous preterm birth. It depends on the study population you want to check. Then you now follow them up again till they deliver to know whether how many of them who were maybe, let's say, who tested positive for Prima-Quick and later eventually had the preterm labor, and those who tested negative and eventually have preterm labor. You want to use it to determine the prediction, whether you can predict those who have preterm labor. So that is cohort study. So it's a long, more of, you are going to meet them at least 2 time points or more. You start from exposure to outcome. So that is a summary of this study design. Here, in the other one on the left, when you are said there is assignment, experimental study. The other question now is, if it's experimental, is it randomized? Yes or no? If it's randomized, it becomes randomized control trial. If it's not randomized, it becomes non-randomized control trial. Then you can also go ahead and subdivide this randomized study into 2. You can say, how were they randomized? You understand? Or as this case, it's randomized and non-randomized control trial. Some also quasi-experimental under here. So we're going to talk about it in detail. This is just, I'll just try to explain to you guys this chart. I've spent time to summarize the lecture. So I can even close now because I've given you the summary of the lecture today, this evening. The other thing here in this picture is what I've already said before. In cohort, it's only those who are exposed, let's say pregnant women, or those who have reduced cervical length less than 25 millimeter who have less than 25 millimeter at 20 weeks. You never know whether they will have preterm delivery or not. So the exposure now is that they have cervical length less than 25 mm. So you follow the cohort of those group of women to know how many of them will eventually had preterm delivery. So if there's a cohort, start from exposure to outcome. But in case control, you start from outcome backward. So usually case control study is usually retrospective study. But cohort study can also be, is usually prospective, though it can also be retrospective. So you have two types of cohorts. Don't even mention up to three, but the major ones are two. That you have the prospective cohort and retrospective cohort. But in case control, it's usually retrospective, usually backward. Okay, so let's move on. So this is also a chart to illustrate the how you can understand this type of study. So in our study, we have descriptive and analytical. But remember we mentioned that we have three major types: quantitative, mixed method, and qualitative. So this all study here is, what we mean here is quantitative studies, because qualitative studies do not follow this pattern. So whatever we are seeing here are quantitative. So we have descriptive and analytical. Under analytical, which I mentioned, comparison, which is a common thing. The only difference now is that in experimental, there is randomization. Why in observational, there is no randomization. I will already explain what cross-sectional is and case control is. Now, under descriptive here, we have cross-sectional and qualitative. Because you don't need to compare. But if you want to do analytical, when you are comparing, you can also have, so you have cross-sectional in two areas: cross-sectional in this analytical and cross-sectional and descriptive. To know the difference. So in cross-sectional descriptive, there is no comparison group. But if you have you really want to do a cross-sectional study where you have comparison group, analytical cross-sectional study. Some will call it comparative. Okay, can I proceed? Can you hear me?
Yes, we can hear you, sir.
Okay, so let's move on. So that is it. These are summary of what we are going to discuss. So the job I have, so and also here experimental have randomized. We have also randomized, but here, we also have two types of randomized. We have parallel group randomized, which most of you do, and we have crossover. Do you understand? But you should also remember that under experimental, we have also non-randomized experimental study, or quasi-experimental, experimental, whereby you didn't randomize, or even if you randomize, it's not using computer-generated random numbers. So here, crossover, I will explain it, what it means by crossover. But as the name suggests, you might recruit a patient into one group. I'll give you an example. If you want to do a trial comparing hydralazine and labetalol for controlling hypertension in women with severe preeclampsia, ideally, what people are proposing is that labetalol is the drug of choice. But previously, your institution is using hydralazine. So you're comparing the experimental drug is placebo, is labetalol, while the control or comparison drug is the hydralazine. So maybe you might have, but you don't know whether that brand of labetalol will work. What is being used is hydralazine. So maybe in your study group, experimental group, you have given them labetalol, and they are not responding. And it's not because, and again, you will not stop giving the woman treatment just because you are doing research. If that one you have given, which is experimental, appear not to be working, the woman is still having elevated blood pressure, you may decide to do a crossover, whereby you can now give the patient another that drug we use for control, which is hadalazine, which you know is working. The only thing that you're just investigating the effect of labetalol, which is a new drug. So in that case, you do a crossover, whereby that drug that was originally used for control are used for the study group, so as to control the blood, because you are sure of that one. The only thing that you're only testing for labetalol, which had not been used before. But because you have used labetalol and the woman is still having elevated blood pressure, you won't allow her to die just because you're doing research. You must give something. So in terms of giving something, you give something that is one used for control, which you know is working perfectly well even before the study. When you're giving it, it becomes a crossover. You have crossed. So you want to know also how many percent, if you are recruited, let's say 100 patients for participants for one group, those who receive for the labetalol group, and another 100 for the hadalazine group. At the end of the day, you ask how many of the participants receive crossover drug, but it may not be everybody that will receive it. It just depends on the indication. Maybe the blood pressure was not able to control in some group. So that will determine what to do. You may be up to that 100, 120 receive crossover. So these are all what we're going to analyze. So that is it, the crossover design. So this is the lecture proper, qualitative design, quality. It depends on quantitative. In quality, it just informs of you are interviewing people. This is a comparison between the two. One, you involve focus group discussion, interviewing people. That is qualitative. Maybe you want to do a research on this workshop we are doing. So then I might decide to interview all the residents attended this. Maybe out of the, how many of you are here now? Let me check. You put 44. Out of the 44, he might select 10 and to interview them on one, the benefits of this workshop, how they feel about what they're feeling. Is there any way you can improve? You understand? Is there any way you can make better? Is there anything you did, maybe what I presented that you don't like, or the way I presented? You ask them questions. That is qualitative design. So that is it. It's a type of study. So if it can be focused, you can do them, ask them individually, or you bring all the 10 together, or you can group them into 2. Maybe some are into surgery. That's surgery section, O and G, and surgery, and we can group them into 2. Those that have surgery and those non-surgical specialties. It can be a focus group, 2 groups now. You can even make them into 10 groups based on their departments. You can be 2 persons per group, and it depends. So it can be interview, can be self-reports. You can ask them about your own observation. These are the things. So sampling, you normally use is for POSIV. You know what to use for that qualitative study. Unlike in quantitative adult observational studies we mentioned, experimental. Mix means both observation, both observational study, experimental, and qualitative. Now, what you mean by mixed method? So these are comparison. But I think you understand what I mean. So that's the most important. You can also use video, text, image analysis to do your survey. There are many ways you can do. They can also do field notes. These are what you use for qualitative study. Interview them. Most interviews, the most important ones. So on. So how do you do that? You can also record it. What if they're speaking, you can record it. You can use your phone to record. You can use NVivo. You can use your Google Teams or to record, or Notra to record, and later you now transcribe what they have said into sentences. There's also a software that can do that. Software that can do that. That's transcribing. So that is it. Then there are a lot of processes involved, but I won't want to go detail because most of you don't do this type of study. But I know in time, all of you will be involved in that's what study that is in vogue in short now. Some of you are applying for grants. The mixed method is a research design, a procedure for collecting, analyzing, and mixing both quantitative and qualitative research and methods in a single study to understand a research problem. So that is mixed. That is what's on vogue now. I know one day, I don't even postgraduate colleges will start accepting this type of method. I don't know, but it can be acceptable. So you utilize this design effectively, you must understand both quantitative and qualitative research. When to use mixed method? When both quantitative and qualitative data together provide a better understanding of your research problem than either type by itself. When one type of research, qualitative or quantitative, is not enough to address the research problem or answer the research question. Like now, you want to do a study that will reduce maternal mortality in ASUT. A more appropriate study design would be mixed method, whereby you interview the patients and also interview the doctors taking care of those pregnant women. You understand? And then you can also conduct the harmony mortality that occurred during the period. So this is a mixed method study. Because information they will give you might help, participants may give you also help in your recommendation for reduction in mortality. Maybe they might suggest that government should make pregnancy care and CS free. So that may be what they will suggest. You can only get this information from interviewing the participants. Data alone will not give you the information. So let me not waste time. I've already explained this. Quantitative observational study, I've already mentioned it. This observation is a study that do not involve any intervention or experiment, where experimental studies entail manipulation of the study factor, exposure, and randomization of subjects to treatment group. So that should be randomization. Randomization is what distinguishes experimental study from observational study. Once you don't do randomization, it becomes observational study. If you have done randomization, they ask you what type of randomization was done. Was it computer generated? And that computer generated there's lack of there's complete absence, or there is you ensure that there is less bias. But some people can do randomization by the way they present, maybe throwing a coin, or the alternate day they present. If those people present on Monday, you can say those who present on Monday, Wednesday, Friday will be in one group, while any participant, women that present Tuesday, Thursday, and Saturday will be in one group. And that in that case, that is not randomized. It was randomized, but they didn't involve the computer generated random numbers. So in that case, it is a quasi experimental. So it's not generally fully randomized using the computer generated number, whereby there's less bias. So I already mentioned this. So from what I said, there are other studies that you call reviews, editorials, expert opinions. They are rated very low in the pyramid. Animal studies, in vitro studies are also rated very low. This is the pyramid. After that, case report, then case series. You should know what the difference between a case report and case series. Usually, different rule of thoughts vary. What constitutes case report? But generally, what constitutes case series is if you have up to 4 cases and above. But if you have 1 case, 2 or 3, it's still a case report. And that's what majority of people believe. But if you read other authorities, they will say only 1 case is case report. And if you have 2 or more, it becomes case series. That is not true. You should have up to 4, at least 4 and above for you to call it a case series. But cross-sectional studies, they're on the same code. Then you have case control, cohort study. After cohort study, non-randomized trials. After randomized trials, then you have randomized trials. Do you understand? And then double-blind RCTs. After that, you have systematic review. That is at the top of the pyramid of RCTs. Now, sometimes you have the word exploratory study. In the word exploratory study is used when the state of knowledge about the phenomenon is poor. It's a small scale of limited duration because it's exploratory study. It is still under observational study, but you also need to put it under either descriptive or analytical. But if you use the word exploratory, you have known what it means. The page of knowledge about the phenomenon is very poor. So you can use the word exploratory. Descriptive is used to formulate a certain hypothesis, small or large scale. Example, case studies, cross-sectional studies are descriptive. But analytical is used to test hypothesis, small or large scale. Example is case control, cross-sectional study or cohort. So I already said this before, so I'm just saying it for emphasis. So in analytical, there is comparison group. In descriptive, there's no comparison group. So in summary, cross-sectional study is a snapshot in time. That is a snapshot study. It sometimes refers frequency survey or prevalence study. It examines presence or absence of disease and exposure at a specific time. The focus is on prevalence and not incidence. So you cannot in a cross-sectional study, you cannot determine incidence in cross-sectional study. It should be prevalence. Although people will now say that, yes, if you are, but incidence can also mean new occurrence. But if you are doing a cross-sectional, you're going to cut across both new and old. So that is prevalence. So you may not be strictly getting incidence for prevalence. So let us take note of this. Okay, I already mentioned that in cross-sectional, it examines the outcome and exposure are assessed simultaneously. Now, take a note of this slide. I would like the class to answer. Study finds obesity more common in women with arthritis. The question now is, did obesity cause arthritis or did arthritis lead to obesity? The question I want to ask is it possible for one to use a cross-sectional study to determine whether obesity can cause arthritis? What do you answer? I'll ask one person. There's one person called okay. Choma Agunyenwa. Can you answer the question? Sorry, I don't know whether you're a consultant or not. Please just answer. All of us are one page, one person. Choma Agunyenwa. Can you use occupational study to determine whether obesity can cause arthritis? Is it possible? Okay, let me ask another person. Chukwuka Eze. You're not allowed to mute. Destiny Nkechi. No answer. Just say something. They're never right or wrong. Okay, let me ask somebody I know here. Emmanuel Ugochukwu. What do you think?
Hello, Prof.
Who is talking? Who?
If allowed me to unmute.
Choma, answer.
Hey, Prof, good evening, sir. I'm saying, I don't think, not really, that's using cross-sectional study to, cannot. Not really.
So you cannot determine causality. Now, the other one is, did arthritis lead to obesity? Can cross-sectional study determine that arthritis led to obesity? That why do the woman have obesity? Because she had arthritis, which made her to stay one place. Can you use cross-sectional study to determine it? I can't hear her again. Okay, another person will answer. Amechi Nwosa.
Okay, Prof. I think cross-sectional study. I don't think so. I think it's because arthritis leading to obesity. It's like we're talking about exposure to outcome.
Okay, so very good. So you can see that you are correct. You can see that there is a strong limitation for the use of cross-sectional study. Most
Prof,
of you,
I think a case control study might be that of cause and outcome. Sorry.
you case control or cohort study? Which one?
Cohort. Sorry, that's the cohort.
Is the
cohort.
The
Yeah,
cohort.
that's a snapshot.
Is a cohort that can answer those questions. Cross-sectional study cannot answer this question. And some of you do it, always like doing work on cross-sectional study for your part 2. You can see the gross limitation of the use of cross-sectional study. Temporal relationship between exposure and outcome is unclear. So you cannot use a cross-sectional study to answer that question. Then let's look at our cohort study. Cohort. In cohort, data are obtained from groups who have been exposed or not exposed to the new technology or factor of interest. So no allocation of exposure is made by the researcher. Best for study, the effect of predictive risk factors on an outcome. Cohort studies follow participants over time. So the process is exposure to outcome. In groups, we have exposed versus unexposed group. I've given you an example. You can also use it to compare the incidence of outcome, cohort study. Unlike cross-sectional study, which you cannot determine incidence. Also, case control study, you can also not determine incidence because it's a retrospective study. So it is only in cohort that you cannot determine incidence. You can see the advantage cohort have over those other two. And cohort study is easier to understand than case control study. Most of you understand this one easily. Now, see this in what shows. We have cohort design, study population free of disease. Now, factor present, factor absent. Then you now follow them up to know whether they will now develop the disease or no disease. Then those who have absent factor, whether they develop disease or no disease, future time. So over a time point, you can see it, the one in green, over a time point. You can see it. So this is a cohort design. So in cohort study, that the follow-up period, it can be prospective or retrospective. Don't know that the follow-up period. You understand? So we have two types, majorly two types. We have prospective cohort and retrospective cohort. There's also another one type they call historical cohort, but we're not going to discuss it today. We pay attention to prospective and retrospective. More important, prospective for your part 2. So in merit is that there's no temporal ambiguity. Several outcomes could be studied at the same time, suitable for incident estimation. The limitation of a prospective type is that it's expensive, time consuming. Most of you will want to, like I know some residents who want to, they only ask me which title they do so that they'll finish it in 3 months. Some people also choose a topic that they will not spend any money. They want to spend millions of naira. They just want to do anyhow, so they can become a consultant. And they will never publish their work because anyhow work can never be published. Unless you go to publish it in Nkwo Enugu journal. So that is the problem residents have. And it's inefficient for rare disease. I may not be usually what I also want to mention here is that the third measure is risk ratio or relative risk. The new name is risk ratio, RR. If you want to do a cohort study, you want to check the inflation statistics, what we use is risk ratio. Odds ratio is used for cross-sectional study and case control study. Please take note. So each exposure identified before outcome and minimizes recall bias. Can calculate incident rates, relative risk, and attributable risk, disadvantages. The limitation I already mentioned. Let me not repeat it. I have mentioned. Now, the last one we're going to talk about is case control study, thinking backward. So, patient with a certain outcome. I already give you an example on ovarian cancer. So, patient with a certain outcome or disease and an appropriate group of control without the outcome or a disease are selected, usually with careful consideration of appropriate choice of controls, matching. Sometimes you can do matching. And then information is obtained on whether the subject has been exposed to the factor under investigation. I will give you an example of ovarian cancer and exposure to oral contraceptive pill. So case control studies start with an outcome, the disease, now ovarian cancer. Investigators look backward in time for exposures. Cases are individuals with the outcome, while controls are individuals without the outcome. So how does it work? You have to identify a group with outcome, cases, that is ovarian cancer, and identify a group without outcome. Then ascertain exposure history. Again, another example could be women that have a current pregnancy loss or do have what they call it, cervical incompetence. You want to check whether there is any risk factor they are exposed to. So you can go back and ask them, those who have cervical incompetence, those who didn't have, and ask them to know whether they had a problem with maybe cervical surgery or anything or trauma before. So that is ascertain the exposure history, chart review, interview, and compare the exposure prevalence between the two groups. And then you can now check whether you can determine. So it's not an easy study to do. So, but it can be done. So most of the studies you guys do are called case control, are not genuinely case control. They are cross-sectional studies. Because for you to do a cross-sectional case control, you must go back to a large estimate, maybe 10 years previously. And most people will not remember those things by then. So useful for rare diseases with long latency. Association usually measure with odds ratio. I've said it before. Now, there's another thing called nested case control study. Nested. Have you heard about it? I know most of you have heard about it. Here, in nested case control study design or case control in a cohort study. Case control in a nested case control study is a cohort study, but it's not a case control in a cohort study. No, not name. So a cohort study also gives birth to a case control study using an incident case. Assuming that you are doing a cohort study now, and eventually you are looking for an outcome. Maybe, let's say, those that have fibroid. Do you understand? And then for cohort, and you want to follow them up to know whether they will be pregnant after surgery, after myomectomy. Then during the course of myomectomy, you were able to identify that some among those who have fibroids had adenomyosis. I mean, those and you understand this example I'm giving, because some people they don't understand what is adenomyosis. So you find out that when you're doing the myomectomy, you find out that, let's say you do myomectomy on 90 women. Out of that 90, 20 of them had adenomyosis in the course of doing the surgery. So you have now determined an incident case of adenomyosis among the 20 out of the 90. We are doing a cohort study to check the pregnancy outcome following myomectomy. You understand? But if I'm doing it because of myomectomy, determine that some people had adenomyosis. So you want to, now among those 20 that had adenomyosis, you want to check whether those people that had adenomyosis had, one of the risk factors for adenomyosis is previous pregnancies. To had previous pregnancies. You now go back to check whether they had previous pregnancies. You understand? Which you didn't get in the history. Or you want to check it using the cervix, the nature of the cervix. No, you can determine the previous pregnancy by looking at a woman's cervix, whether she's a virgin or not. So that becomes a nested case control study. When you're now studying the adenomyosis in a cohort of women that have fibroids. So in the nested case control study, cases of the disease that occur in a defined cohort are identified. And for each, a specified number of matched control. So those who we did myomectomy, those kids that have adenomyosis, you now have a control of who don't have adenomyosis, which are selected as control. They are selected from among those in the cohort who have not developed the disease by the time of disease occurrence in the case, and you now study them. It becomes a nested case control study. Please take note of this. Now, before we round off this type of study, I want to mention something about measurement of outcome. I'm not going to mention all of them, but I'll just mention few, because I noticed that some of you are also have a problem, depending on the type of study you are doing, determining the outcome, outcome measures or measure of outcome to use. So there's some confusing fractions. Identification of and quantification of outcome is the business of research. However, slippery terminology often complicates matters for investigators and readers alike. So far, I've already told you guys that you cannot determine incidence rate in cross-sectional and case control study. But some of you went ahead and do incidence among them. And then even if you're using incident rate, how do you define incident rate? For example, rate. The term rate as a maternal mortality rate has been misused in textbooks and journal articles for decades. So rate is often used interchangeably with proportion and ratio. Some use it interchangeably, just multiplying by 100. That is not always true. So what am I to? So I want you to screenshot this picture on this page. I don't know what you will see it. But what he's talking about is, if you're dealing with a ratio, you ask yourself, is numerator and denominator included? Is numerator and included in denominator? If the answer is yes, then you ask yourself, is time point included in the denominator? Is time point included in the denominator? If the answer is yes, then what you're determining is rate. But if there's no time point in the denominator, then you use, if the answer is no, it becomes proportion. But if the numerator and denominator is not included, it becomes a ratio. Most times you don't do ratio, unless it depends on the type of work you're doing. Maybe you're doing, some people are doing ratio of creatinine albumin ratio if you're doing on preeclampsia. So in that case, the numerator is not included in the denominator. So you can see that proportion is better, because if you want to check the incidence rate in a study, you must define it based on time form. Use after 6 months or 1 month or 3 months or 1 year. But the best thing is to use is proportion. The proportion of both of them are also expressed as percentage, but you're not going to consider time point in that study. So I would prefer some of you who are doing RCT, cohort studies, to use the word proportion instead of using incidence rate or something, because it can make a lot of people to misunderstand what you say. Because once you use rate, you have to deal with time points in question, which most of you will not like to state. That's the rest of this slide. Now, finally, let's talk about experimental design. So, but before then, we have what we call systematic review and meta-analysis. So what's the difference? After in systematic review, is any review that systematically identifies, select, and appraises relevant research. While meta-analysis is a statistical technique in systematic review to integrate the results of the included study. So the mathematical aspect of the systematic review is the meta-analysis. Under a experimental, we'll talk about randomized control trial, which I also said that in this study, a group of patients is randomized into an experimental group and a control group. And these groups are followed up for the variables and outcomes of interest. So the study is similar to cohort, but the exposure is randomly assigned. That's the only difference. In a cohort study, you don't assign exposure randomly. While in randomized control trial, the exposure are assigned randomly. They now ask the type of random used. Is it how it was assessed, whether it is computer generated or not, and that will determine whether it is through a randomized trial or quasi-experimental study. So this picture illustrate what I wanted to show on experimental study. So the cardinal thing is randomization. Once there's randomization, it becomes an experimental design, randomized trial. If there's no randomization, then it might be cohort study. So take notes. Now, if you talk about trials, you can have controlled and not controlled. You know that there's some studies that will have control, but some will not have control. Trial. Under control, you have randomized and not. I've already mentioned this. You can randomize or not randomized. If it's randomized, you ask yourself, is it blinded or non-blinded study? And you should also know how to blind study. I think it's beyond the scope of our this evening workshop. We won't be going into details how to blind and not to blind. They are beyond the scope of this our workshop today. But this is how you can classify RCT trials, controlled and non-controlled trials. If it's controlled, is it randomized or not randomized? If it's randomized, how? Then is it blinded or not blinded? I also showed you this graph before, so don't need of emphasizing it. So in a randomized trial, an experimental comparison study in which the participants are allocated to treatment or control or placebo group using a random mechanism, best for study the effect of an intervention. So a control trial, that is one a crossover design. A control trial where each study participant has both therapies. Example, is randomized to treatment A first. I say at the crossover point, they now start treatment B. I mentioned an example before in Hadaladin Beta law. So only relevant if the outcome is reversible with time. Example, if the symptoms are reversible. Like the issue of the blood pressure, if you give it, after some time, the effect will wear off. The woman will now return to either become high again after reducing the blood pressure. Now, in terms of analysis, RCT is also divided into two: intention to treat and per protocol analysis. In intention to treat analysis, it means that all the randomized participants are included in the final data of analysis. Usually, that is what we call consort flow diagram. That's what we use for RCT. Sorry, I didn't include it in this slide, but you should know about consort flow diagram. In per-protocol analysis, only patients who complete the trial according to protocol are analyzed. Can you see the difference? Some of you will start a randomized control trial, recruiting 90 participants, 180. At the end of the day, 5 are lost to follow up in one group, while the other 10 are lost to follow in the other group. And you will now forget about them. And don't analyze the one that's going be 70, 80. So in this case, they're going to be biased because you don't know why those ones that didn't come back, whether they died because of the drug you gave them or the intervention you gave them. So if they ask you which one is better analysis, is intention to treat or protocol analysis, what do you answer? I think all of you will agree that it is intention to treat that is better. You are correct, because even if you're doing a systematic review and you want to check the to check the quality of this trial, it is this and this. We also consider this intention to treat analysis in the assessing for study quality. Studies that analyzed by intention to treat are rated higher than the one for protocol analysis. Again, there's also a way you can analyze in the exam for your part 2. You can do both. You can do both. If they allow you, you can do both. If you have a loss to follow up. And if you analyze both and the difference you get is not significantly different between when you analyze by intention to treat and when you analyze by protocol analysis, you still report it that way. Because some of the reviewers also want to know whether if you analyze by protocol, whether it's difference, there's a difference in the outcome. So you have to analyze the two and report the two. If the two are not different, it becomes good for you to report it that way than just analyzing only per protocol without analyzing intention to treat. Now, there are also 3 types of RCT. We have superiority trial. This is the prototypical randomized clinical trial. It is superiority trial. This primarily aims to ascertain whether an experimental or novel treatment strategy is superior to the established reference standard or placebo strategy in improving health or functionality outcome or mitigating morbidity or mortality outcomes. So most studies, most of you will do this superiority trial. That's what is encouraged for you. Because you are saying that what you are proposing is superior to what you used to use before. But if you want to do equivalence trial, however, under circumstances when inferences about superiority cannot be demonstrated, the next best strategy is to assess the equivalence trial. You understand? So the experimental or new treatment is equivalent to, or at the minimum, not unacceptably worse than the reference standard treatment. So this introduces us to the concept of equivalence trial and non-inferiority trial, respectively. So in equivalent trial, what we're trying to say is that the experimental or new treatment is equivalence. So in equivalent trial test, if a new treatment is neither better nor worse than the existing treatment, meaning its effect is similar within a defined margin. Example, 2 antihypertensive drugs have similar blood pressure lowering effects. So the goal of the equivalence trial is to demonstrate that the experimental or new treatment strategy are equivalent to the reference standard or the standard of care by employing a margin of either side of 0, which depicts the maximum tolerable difference for equivalent. You can use a margin of 0.5% margin. If the computed confidence interval of the experimental or new efficacy outcome derived at the end of the trial lies strictly within minus gamma also plus within the said equivalence strategy is said to be equivalence trial to the new treatment, to the reference standard. Now, what equivalence trial is all about. Let's give two scenarios. A scenario, I mean, you have two different antihypertensive drugs. It is available for managing blood pressure. Let's say labetalol and hadalazine. One is an older established drug, hadalazine, and the other is a newer alternative, labetalol. So the goal is not to show that one is superior, but because that other one is working. But if the newer drug is equally effective, then it can be used, and maybe it may even have less side effect. You know what happened in carbetocin and oxytocin. So an equivalence trial will be used to show that the mean reduction in blood pressure from the newer drug is similar to that of the older established drug within a predetermined range of clinical equivalence. This might be a range, for example, that the difference in the blood pressure reduction is no more than 2 millimeter mercury. Because if it's more, just like what if you're treating a hypertension in pregnancy, the teaching is that you don't reduce the systolic blood pressure to less than 90. If you're treating severe hypertension, severe preeclampsia, hope you remember. So if you're using a drug, so you're now saying, okay, from 110 to 90, which is about 20. So you may specify that the range for which the difference between the blood pressure, the systolic blood pressure reduction should not be more than 20 millimeter mercury. That is the safety margin or clinical equivalence margin, which you are meant to get if you're doing equivalent trial. To the extent that if eventually it goes below that 20, then it's no longer clinical equivalence. You understand? But if it's within that 20 setup, then you can just probably say that the drug is a clinical equivalent trial. Unlike contrastingly, in non-inferiority trial, while the experimental or new strategy is definitely not better than the reference standard, it is not unacceptably worse or non-inferior if the lower limit of the computed confidence interval around the difference between the experimental and new drug and that of reference standard does not extend beyond the predefined margin, also known as the non-inferiority margin. It's similar to equivalence, but here you have to have a margin to which it does not go beyond. And it is not unacceptably worse. Some drugs may be said to cause, like for instance, egometrin can cause headache and pyrexia. You understand? So most women doesn't like that about headache and even vomiting, which is a worst case scenario. So, but if you're using oxytocin, which is an alternative now, and you want to do non-inferiority trial comparing egometrin and oxytocin, end of the day, you find out that the side effect of oxytocin is worse than that of egometrin. Will you now say that it is non-inferior to the egometrin? The answer is no. So the point that even if it is a worse, it had a side effect. The side effect of the new drug should not be unacceptably worse than what we used to have before. So it becomes non-inferiority trial. So each of them had different ways of calculating sample size. I'll give you an example here. A manufacturer develops a new, less expensive version of an existing biological drug for severe psoriasis. So the new version is structurally identical to the original, but has a different brand name. So a non-inferiority trial will be conducted to show that this new biosimilar drug is not unacceptably worse than the original biological drug in terms of efficacy, safety, and immunogenicity. Just like example I gave you on egometrin and oxytocin. So the goal isn't to improve that the biosimilar is superior, but that it performs comparably to the established treatment. Okay, so what else so this is the conclusion for this hour own. Do you have any question? Otherwise, we'll go to the last topic on development of study protocol. So do we stop here or we'll finish the whole lecture before you ask question? Ezra.
Prof, I think we should continue.
Okay,
Maybe at the end of the
At
presentation.
the end of the day, ask question. So
Yes.
what I'm going to talk now is also related to the study design. However, study design is just one aspect of it, of the protocol development. I have already went straight detailed on study design. So this is in the learning objective for this one. You guys should be able to know the importance of study protocol and also steps for developing the study protocol, and then we'll make a conclusion. These are the three key things we're going to discuss. So this is like a step-by-step guide to creating a robust study protocol. The first one is that you should have research hypothesis, research question. I would like all of you guys that any work you're going to choose for your part 2 should be a work that you like, you have joy in, or something that during your course of your training as a resident, it will giving you some concern and you are interested in finding solution to it. Now, it might have had a research question. How would this thing be prevented? Is there any way we can do better? So you must articulate your research hypothesis or objective. Ensure that the question is specific, measurable, achievable, relevant, and time-bound. They should be smart. The objective should be very smart. You should have research objectives. And you may have specific objectives that are up to 2, 3, 4, 5 for your dissertation part 2. What you want your subject to solve. Then that is the first thing. Second one, you have to conduct a literature review. You have to search to check whether there have been previous study on the topic. Very, very important. So you review the existing studies to provide the context. You also identify knowledge gaps your research will there, because if some of you will see a work done in a Navy, maybe you want to do comparing ergometry and oxytocin for third stage labor management. It have been done in Navy. We have already done it in the Navy already, and you want to repeat it in Parkland, but you want to repeat everything verbatim. It should not be good that way, because what should be better is look at the previous study, the one we did. Are there areas we did not do? Are there areas that we considered in our limitation of the study? Gaps that we suggested that we have to do in future study. That is the area you should concentrate on. You cannot say that previous study was done in a new way, but they didn't do this, they didn't do this. And you can also get the gap in knowledge by reading the discussion aspect of the work, where the researchers are talking about their limitation of the work. From there, you can know the gap that are left, which your own work now will fill. That is how this is of conducting a literature review, to determine the gaps in knowledge, and not just to replicate the work in a suit, but to replicate the work while addressing the gaps already pointed out by previous studies. That's the essence of the literature review. That's the second step. The third one is to specify the study design and population. So that comes to what we have just discussed. You now determine what study design will you do. Like the one we did in NAWI, it was an RCT. So you may not like to go lower. Maybe we did a double single blind. You now say, okay, it is the NAWI people did a single blind. Let me go for double blind if it's possible. So you now choose a design, RCT, or observational study, or qualitative, or mixed. It might be that we did only RCT. You might decide to do mixed method between the qualitative and RCT, and it may be more robust, where you interview the patient itself. interview them, and to see what they want, improve for preventing PPH. You have to define inclusion and exclusion criteria and sample size. These are part of the study design and population. You have to tell how many sample size will you use? What is formula? Because each depends. If you are working on RCT, the sample size you're going to use formula, it depends on the type of RCT, whether it is superiority, non-inferiority, or equivalence. They have different samples. Even in observational study, if you are doing formula for analytical cross-sectional study, which is different from the formula sample size for calculating descriptive cross-sectional study. Most of you make a lot of errors in this sample size issue. Once they say it's cross-sectional, they start using Pritchard Fisher's formula for analytical cross-sectional study. It is grossly wrong. So there's a standard formula for analytical cross-sectional study, also for cohort study and case control study. Some will just use the one used for Pritchard formula for everything. It's unacceptable. Pritchard formula is only for descriptive cross-sectional study. Now, anyway, I'm not talking about sample size because the person who is going to teach it will explain more in detail about it. Now, the first step is data collection and analysis. You have to determine data sources, the instrument you're going to use, and procedure you're going to use for collection of data. You also outline the statistical methods, analysis software you're going to use, like APinfo, SPSS, which version, or if you're doing meta-analysis, are you going to use Review Manager software, or Starter, or which one, which version? All these things should be stated under protocol. And data sources, instrument, and procedure should be well detailed. Then, ethics and timeline resources. Also talk about the ethics and timeline. So address the informed consent, confidentiality, and risk. And now create project schedule. Identify the funding, staff, and refine your protocol before finalizing. That means you need to send the protocol to others to read. Maybe your supervisors. Don't just submit to college or to ethical approval when you are not, who have not read it. Because when you read it, they have to refine it. They always find one thing or the other. So always learn to give it to your peers or to your supervisors. So this is the conclusion. So the class to conclude, what have you learned today? So among the conclusion, is just this thing to refresh you on levels of evidence. This type of, so I think this one have overflow, so you know what this is all about. So thank you for listening. Questions?
Wow. Thank you so much, Prof. Thank you so much. That was quite deep on study designs. Thanks so much. It's time for questions, please. We can have our questions. You can unmute to ask your questions, or you type and send to the chat box. Prof, thank you so much for this very engaging lecture. Thank you so much. These questions. I hope I can be heard.
Yes, I can hear you, but in the chat, I didn't see any question in the chat, only comments.
Okay.
For now.
Yeah.
So they can ask direct, they can unmute and ask. Okay, somebody was saying, I like, again, difference between rate, ratio, and proportion, sir. Okay. The other person is saying, can we have the slides, sir? Yes, you can have the slides. So,
Oh, thank you, Prof.
so what I'm saying about rate and proportion is that I'll prefer you guys to be using proportion because maybe proportion of, you want to check, maybe some of you are doing an RCT. It will be better for you to determine, use proportion than writing, you want to determine this. Maybe you are doing an RCT on echometry versus oxytocin for preventing, for managing women in third stage of labor. And the outcome measures include diastolic hypertension, hyperpyrexia, nausea and vomiting, the headache, and repeat egometry and so for the use of this thing. The use of other alternatives for controlling ppH. So in this case, you can use proportion for the outcomes as the measure than using, you want to determine the incident rate of headache, the incident rate of diastolic hypertension. No, you can say, you want to determine the proportion of participants that will be having headache, repeat alternatives, nausea and vomiting. The reason is that if you want to use rate, incident rate, you have to define the time point. Do you understand? You can say what's the incidence over 1 year? What's the incidence over 6 months? What's the incident rate for that disease or that problem over 10 years? So, but your work is RCT, you don't work with time. So it may be difficult for you to determine the rate, strictly speaking, but you can determine the proportion because proportion does not have a time limit for it. Again, sometimes incidents, the rate is had to do with 100%. So that means you must get up to 100 participants or 100 cases. But in proportion, you can even get 20, 3, 1 is a proportion. So whatever you get, you report it. But you can also express it in percentage. So in this case, they're all ratio, but you can multiply it by 100. You understand? So that's acceptable. In that case, it's safer. And again, the type of analysis you're going to use. For instance, if you're using proportion, it should be the number. And what you use is, you can use chi-square or Fisher exact. And you can determine the risk ratio and 9% confidence interval. But if you're using rate as the outcome measure, maybe incident rate or the rate of diastolic hypertension, the answer you're going to get will be in percentage. And in that case, it is not going to be, you're not going to use chi-square again to determine it because it is numeric. And that numeric data will require you to get the mean and standard deviation or median and interquartile range. And for you to know what to use, you must do what we call, you check whether the parameters were parametric or non-parametric. And for you to determine whether it is parametric or non-parametric, you have to check normality testing. It should be done. And you don't need saying it by word on it that it was done. You have to state it in the table, clearly in the work. And most times your statistician may not do that, and it becomes problematic to defend in the exam. So you better use something that is easier to interpret in an exam. So that's how I can have thrown more light on it. And I said I prepare proportion for you guys to use it than using rate. Or ratio can be used also, but it depends on what you want to achieve. If your objective is to determine a particular ratio, then it becomes clear that what you're achieving. And in that way, there will be no unit. It should be, there will be no unit in ratio. Just like saying, PCV, we also put percentage in PCV. But it's supposed to be no percentage. So that is it. What I said is clear to you guys. They say, thank you for Prof for the lectures. Please, how can one register his dissertation proposal with the RCT board? Yes, you can use a Pan-African Clinical Trial Registry. And registering it is free. So maybe I will share the link to your organizers. He will send it to you. But you can Google that the work I published on 40 rules, Professor Eleje's 40 rules of proposal and dissertation writing, and it is available online. So if you Google now, you get it. The link, how to register it, is there. So 40 rules of proposal and dissertation writing by Eleje. You can get it online, free online. So you can, but one of the eligibility criteria here is that you must have, not necessarily you have an ethical approval. But even if you don't have, you can still register it. You can now tell them that you have not gotten ethical approval. They'll ask you, when are you going to get ethical approval? You state it. And they'll ask you some small questions, which you will fail. Then if you have challenge, you can consult your lecturers or friends who have registered. Those in ONG. Those in ONG in ESUD. Some of them are specialists in registering activities. So we have trained them. So if you're not in ONG, consult those in ONG who can help you. Or meet us so you can register it. You better register it before starting the study. So what I advise people is, once the college approves the proposal, the first 1 week of approval, use to register it and get it, and then start the study. Otherwise, if you start the study without registering it, it's going to be a problem for you. At the end of the day, we cannot publish it, or you start lying, which is not necessary for you as an academician. The person said, Prof, thank you for educating. What is simple random sampling certified? What is beyond? I don't think it's part of what I'm supposed to teach people today. Can they be differentiated from study design, sir? No, the simple random sampling certified and cluster are different from study design. These are called sampling technique. It's a topic of its own. They're different from randomized control trial. No, they're different, because you can also say they are simple random, but they're not genuine, truly simple random. Sometimes it can be stratified or clustered, depending. But the whole randomization sequence, randomization we do in RCT, is entirely different. But you can use simple random for observational studies, stratified cluster for observational studies, like case control, cohort study, and so. But for RCT, it's a different ball game. That they are different. That people will think that they're simple random, but it's not like that, because in RCT, sometimes when you randomize, do you replace some? Usually randomize and replace, some randomize and do not replace. So it's not straightforward. So you use computer. Computer generated is better. So in stratified, you have to stratify people. For instance, maybe you are using among pregnant women who have obesity. You can stratify to those who are obese. Now, simple random, you don't just randomize, no certification. Everybody you recruit. Once you qualify, you recruit. In cluster randomized trial, yes, there's also called a different, the random RCT called cluster randomized trial. It's also randomized, but you may put people in cluster depending on the type of work you are doing. maybe we want to check the effect of educational intervention in improving adolescents in uptake of HIV. You can do cluster, whereby if you come to state, Anambra State, you can now come to New and form a cluster and study them. Instead of studying individual, you now study the clusters of people in New. And so this one is the cluster on the mice trial because the individuals are form a unit, but in each cluster, you should also determine the sample size for each cluster you want to use for each state. They call it cluster on the mice trial. So that is it. Let me check other questions. He was asking, let me check the question. Thank you, Prof, for the collective. What is the standard formula for sample size as regards a study for awareness and perception of issue among pregnant women? This one is a cross-sectional now. So you can use Cochrane formula or Christian's formula. That's what you should use because it is a descriptive cross-section. But before you know the formula you use, ask yourself, this study on awareness and perception, do you have a comparison group? If the comparison group, if the answer is yes, then you know it is analytical cross-sectional. The sample formula you use is different. You're not going to be Cochrane or Fisher now. You use the appropriate formula for analytical cross-sectional. Do you understand? So that is what answers the question. So everything depends whether it's analytical, whether you should have a comparison or not. Because if you have a comparison group, you should also factor in the sample size calculation for the comparison. And it should be less than when you use Fisher. Said ask a question, but admin could help on mute, please. Okay, what you want to talk? Nobody want to talk. Okay, the questions are finished.
Okay. Okay, it seems somebody wants to to ask question directly.
We're telling you to mute.
Oh, so sorry. Let me see how I can do that on my end. So see, please, if you can unmute now.
Okay, thank you, admin. Hello. Yeah, admin,
Yeah.
thank you. Prof, good evening, sir. Thank you, sir.
Yeah, good evening.
Okay, I think thank you for adding more insight as usual, at least the issue of case series and case reports for that knowledge, and also the issue of odds ratio in respect to the cohort study and case controls against the relative risk. That's for cohort study for relative risk. So, Prof,
Yes.
my input is just based on some of the abbreviations that were reached, and it's a common question the external assessors might want to ask people that use RCT, like this use of PICO, because you used one PICO and the other one PECO.
Yes.
There are various meaning and how it can reflect to some clinical scenarios, like you just mentioned, like this labetalol and hydralazine in respect to particular population. Like in some of these Southeast Sorghum or some of these, you see them ask you, do your title of your study follow this PICO guideline?
Okay.
So for people to understand, and also you also mentioned these consorts. Sometimes you see some assessors asking you, what's the meaning of that consort in respect to RCT? So like, I mean, based on many people may have heard us say consorts, but how it relates to the consolidated standard for the reporting of those trials, maybe the meaning is them. And some of those things can throw people unaware.
Yes. Okay,
sir.
Go ahead. Go ahead. Are you finished?
Yes, he's done with the questions.
Okay, if He's not asking question, he's making a comment. I don't think he asked a question.
My question now, Prof, my question now is, like if you're introducing an RCT and there's a new drug, which is an intervention drug, they are the same drug, but of different routes or routes. You want to, experiment based on different routes of the same drug.
Okay.
And now, can that part of RCT over a given period, maybe 6 months, using the same population, maybe pregnant women that are up to 10, and you want to use that particular drug, maybe let me take, for instance, now, oxytocin, either IV or IM. I want to know, can that particular approach be as non-inferiority or maybe one being equivalence?
Well, it depends. It depends on what you...
I don't want to use misoprostol, but I just want to put another, because of my own concern. That's why I'm asking that question, Prof.
The first thing you do, which drug do you mention now?
You want to use oxytocin, maybe
and
IV oxytocin and IM in respect to achieving
the same drug or different routes.
Different routes, yes, sir.
Okay, whether it is superiority. Yeah, what we are trying to check now is whether the IV is superior, superior to IM. Now, what you are testing now.
Yes. Okay.
You are testing the route of administration. The route of administration is what you're not testing. It's not necessarily the drug. But in as well, you may be also testing the drug in the sense that what you are trying to assess is whether the drug perform better. Is it more superior if you give it IV compared to if you give it IM? But when you're talking about superiority, you also check both the efficacy and the adverse effects.
Okay.
You understand? So, but we generally, what you normally should be checking is the superior. That is the prototype of trial to check that IV is superior. But sometimes, if we are using two different drugs and the company, you don't want to. That the study we did last time, we are comparing Amnesia and
Amnoquick. Okay.
These companies are standard companies. Amnesia is already established as the standard for diagnosis. So in that type of case now, we cannot do superiority trial. It's wrong. You can't do it. Because if you're doing superiority trial, you're not trying to say that Amnoquick is superior. The Amnesia is already the gold standard. So what only thing you can do is that Amnoquick is equivalent, or Amnoquick is non-inferior.
Non-inferior
to Amnesia. So that thing we can only do, because you cannot test superiority here, because Amnesia is already superior. They're taken as the gold standard. The sensitivity is almost 98%, 97%. So you cannot be testing again to say that Amnoquick is superior. And again, for you to do that for a study, you must get permission from the company. Okay. So what you can only test is non-inferiority or equivalence, meaning that at the end of the day, if it is non-inferior or equivalent, then you can now, the information will now be that wherever you are, if you have Amnoquick or Amnesia, whatever is available, use it, because two of them are non-inferior to each other. You don't understand?
Yes, sir. Yes, sir. Prof, can I relate
these are the things that can influence what you do. So the same thing in the IV now. You can test superiority in IV, which is IM. But if you are checking maybe gometrin and oxytocin and buscopan and gometrin, you can test if the gometrin have not been able to achieve what is based on the previous study. You know that what we call non-inferiority margin. You mentioned it.
Prof.
Margin of safety. And so there are some that you check the confidence interval is already made that there's nothing you can do to say that it is superior. What you rightly
so Prof, can I use this scenario? What if you're using misoprostol and there's a standard of practice already in the department, maybe they're using rectal and you want to introduce another route of that misoprostol in achieving reducing blood loss during a procedure, and they are of the same strength, can you try to make it as a non-inferiority that the one origin standard, when you introduce it, is not inferior to that? Or
What you do
equivalence?
is, you say it's equivalence. You can do equivalent trial.
Okay, Prof.
But if there has not been any study, first of all, you do superiority trial, whether it is superior to it.
That means they've done the trial in some other place. You want to replicate it as a local, listen, in your center.
If it is superiority, you can still repeat it as superiority trial in your center. You can. But what you should now be saying that the study were done in non-population, maybe non-black population. So you want to check whether it is still superior. If they did superior trial before, you cannot repeat it elsewhere. If the environment is different.
Okay, Prof.
But I've told you factors that can affect. Most time, what you should be doing, most residents will be doing is superiority trial. That is the prototype, what you should be doing. You can only do equivalence or non-inferior if you are sure, you think that that new drug can be used as an alternative. What you felt, if you feel that it is not superior, but it is the equivalent or non-inferior, then you do non-inferiority trial to illustrate that even though this is the gold standard, we also have other drugs that are not inferior to it, alternative.
Thank you, Prof. I'm done, Prof.
Okay.
Okay, Prof. Thank you so much for the excellent delivery. Thank you once again. We really appreciate you. So sorry that I logged in late and did not take your profile appropriately. Please, I'm very sorry about that. Meanwhile, the president of the association just called to let me know that he's entering for an emergency surgery right now. So he would have loved to give his vote of thanks to appreciate your being available to take us. So on his behalf, we are saying thank you so much for your time and for availing yourself to take us on this topic. Thank you, sir. We really appreciate.
You're welcome.
So as you promised, we'll be getting the slides, and for those
just
interested.
send me your email in WhatsApp so I can forward it to you.
Okay. So please, if you're interested in the slides, you can send your share your email so that we can use that to upload the slides. Thank you, Prof, once again. And everybody have a good evening.
Thank you, Prof.